This is teaching video for congenital fellow. Anterior sphincteroplasty for patient with fecal incontinence after anorectoplasty for treatment of congenital atresia. The patient was diagnosed with atresia at birth 14 years ago, concomitant with abdominal distension and vomiting. After abdominal massage, stool could be discharged from the vagina. She was diagnosed with congenital atresia with vestibular anus on February 25, 2011. She had underwent anorectoplasty. Stool could be defecated from the anus after surgery. 1 year after surgery, due to recurrent abdominal distension, constipation, and diarrhea, she was diagnosed with Hirschsprung disease with bilateral indirect inguinal hernia at the other hospital. On December 29, 2011, she underwent radical surgery for Hirschsprung disease laparoscopically and bilateral ligation of the processus vaginalis. After surgery, clinical symptoms she complained was significantly improved, but she suffered severe fecal incontinence with uncontrollable passage of feces and gas, requiring long-term use of diapers, which severely affected her quality of life. Wetzel incontinence score was 20 points. Physical examination. Petrous anus may be seen with relaxed and weak anus sphincter complex under mesotomy position. Anterior sphincter defect can be seen on MR image and on ultrasonography. Patient's position on operating table in mesotomy position. A spinal and general anesthesia is applied. Transperineal cavernous incision was performed. Injection of adrenaline saline was conducted in the right vaginal septum. Sharp and blunt dissection formed along anatomical plane between rectum and vagina until reached the level of later 9 muscle. The divided ends of the external anal sphincter on both sides were isolated, respectively, with reservation of surrounding fatty and cicatricial tissue. The wound was irrigated with povidone iodine and normal saline. Plication of the internal anal sphincter was performed with 2 to 3 stitches. Overlapping technique was utilized to complete the external sphincteroplasty in the manner of matrix suture with 3-0 absorbable vacuum sutures. Drainage tube was placed in the rectal vascular septum. The perineal wound is reconstructed in the shape of Y, and central wound remain open for drainage. Postoperative management. Diet not allowed for 1 week after surgery. Parenteral nutrition was carried out. Antibiotic prophylaxis was utilized for 2 to 3 days. Loperamide 1 milligram twice a day for controlling bowel movement. 1 dressing change once a day. View wound 2 weeks after surgery with anorectal function significantly improved.